Welcome to our Primetime Alive program, Hereditary Breast Cancer, What Men and Women Should Know. I'm Vicki Newell with the Mary Greeley Primetime Alive program. As a reminder, if you want to join Primetime Alive, find out about programs, sign up for a program, you can go to our website, mgmc.org/PTA. Our presenter today is Stephen White. Stephen is a licensed genetic counselor with the Bliss Cancer Center at Mary Greeley Medical Center. He has been helping patients with hereditary risks for adult onset cancer since 2015. Please welcome Stephen.
Thank you. Yes, my name is Stephen White. I'm the genetic counselor over at the Bliss Cancer Center. It is a gorgeous day. This is one of my favorite times of year, but ever since I was a kid, this was also my allergy season. So if you hear kind of a stuffiness, that's a little bit of where it's from. There's a high level of enthusiasm I have that probably won't be communicated through that stuffiness. So I appreciate your patience. Today, I'm hoping to talk about hereditary breast cancer. I was here a couple of months ago to go over kind of more generally hereditary cancer, a variety of types. With it being October and Breast Cancer Awareness Month, we're focusing in on hereditary breast cancer. And so today I'm hoping to talk about that from a couple of perspectives. I think that we do a pretty good job addressing that this is really important for women, daughters, nieces. We may not talk as much about how men can play a role in this. And I'm hoping to focus in on that so that the men that you're partnering with, whether they be spouses or brothers or sons, that they can know what this means for them too. Because it's not something that affects only one side of the family. It's not something that only affects females. This is something that has impacts for both men and women in the family. Today, I'll be reviewing some of the things we covered in August as a refresher. One of the things is just redefining hereditary cancer risk. This is basically acknowledging that somebody may have a higher than average risk, and that is specifically due to a gene mutation. When you think about genes, mostly I just want you to think of these as the instructions. Things you're getting from mom and dad's side of the family about how tall you can get or what color eyes you can have. These genes also have instructions that keep the body healthy. In this case, we're going to be looking at tumor suppressor genes today. So if the instructions work, tumors are suppressed, or in other words, they prevent cancer. And so when we're looking for hereditary cancer risk, we're not really trying to figure out who's got the genes or not. Everybody's got these instructions that help the body stay healthy. We're mostly focusing in on which one of those may not be functioning correctly. If they're not preventing cancer, that might be what's causing higher risks. In terms of why we talk about hereditary risk, a lot of this comes down to how is it going to change medical care? For individuals, if you're fortunate enough to find this out before getting diagnosed with a cancer, it may tell us more about what sort of screening options you have. So if you find out you have a higher than average risk for breast cancer, you may get access to things like starting screening sooner or more often. For something like mammograms, you may get those once a year anyway, but your doctor may recommend adding something on a 6-month rotation, like mammogram and breast MRI, or mammogram and breast ultrasound. The idea behind that is if we know there's a higher than average risk, we don't want you to get screened like the average person. We want to do a better job. And so often that may look like screening twice a year rather than once a year. Some individuals may go beyond screening. That's where we start. Up here, when I say surgical recommendations, this isn't the sort of thing where finding out you have a gene mutation means you're signing up for surgery. But some individuals decide, hey, I'm already doing the screening. Is there anything else I can do? So about a decade ago, Angelina Jolie made headlines talking about how she was taking surgical options, removing both breasts because she found out that she had a hereditary breast cancer risk. That's not going to be the right decision for all of our patients. But for some, if they feel like, hey, I want to reduce risk where I can, this could be an option that we send you to a surgeon to talk more about what options you have. If we determine a hereditary breast cancer risk, there are also medication options available. Sometimes these are called hormone therapies. As you might imagine, not only could they decrease breast cancer risk, but there could be some significant side effects with things like that. So before deciding on medication, we'd also have you say, hey, screening's what we want to start with. Do you want to talk to an oncologist or another doctor about what other options are, like medications? One of the things I'll be really focusing in on today is about family risk. So if you find out that you've got a hereditary risk for cancer, you may have relatives that have the same risk. Those could be children, those could be siblings, those could be more extended relatives. If they find out they've got a hereditary risk at a young age, they may be able to start screening sooner. If they find out the risk is there, they may screen more often as well. And so this is kind of a summary of this would be, how does this improve what options you have, but also how does this improve the options of your relatives? In terms of finding these hereditary cancers, these things tend to be rare. About 1 in 10 to 1 in 20 cancers is thought to be hereditary. So it's not going to be each and every case. A lot of what we're looking for are patterns. And so this would be something like you and your mom's sister all had breast cancer. That looks like a pattern affecting multiple generations. That may be due to a hereditary cause, and you may be a great candidate to do a test. This may also look like getting diagnosed at young ages. Early onset breast cancer is considered at 50 or younger. A lot of breast cancers are beyond that. Breast cancer, unfortunately, happens to a lot of individuals, but a lot of those times it may be in the 60s, 70s, or 80s. If you're seeing breast cancer in the family in the 30s, the 40s, even early 50s, that may be a clue that there's a hereditary risk there. We may also be looking for multiple cancers. Hereditary breast cancer is often linked with other cancer risks. One of the classic associations is breast and ovary cancer. That if you've had both breast and ovarian cancer, we may think there's an underlying hereditary risk involved there. But there are other connections as well. Some hereditary breast cancers can link with things like stomach cancers, thyroid cancers, still others. So if there's more than one cancer, we may want to take a closer look. There are also certain rare cancers. This is the area where you don't have to focus in on all the details. I'd expect your doctor to be paying attention to the rare things. But one example is that out of breast cancer, ductal breast cancer is more common than other types. And that's referring to where in the breast it's affecting. There's also a type called lobular breast cancer. That doesn't happen as often. But if you're having 2 ductal breast cancers in the family, that's not as much of a risk factor as having 2 lobular breast cancers in the family. So 2 rare events stands out to us more than 2 more common events. And in terms of pathology, that's where the cancer gets put on a slide and sent to the doctor who looks at it under a microscope. They can do a variety of tests to see, well, what's this cancer like? How do we know what sort of treatment to consider? In that process, they may find things that tell us, is it higher or lower risk of hereditary causation? If you've heard of the term triple negative breast cancer, this is one of those, where there are 3 things that they're looking for on that pathology slide, mostly from a treatment standpoint. What treatment might work best? But triple negative breast cancers also can have a higher than average risk of a hereditary cause. And so that's one of the many things that may show up on a report. Mostly what I want you to be thinking of is, do I see patterns in relatives? And then some of the others are more for the doctors to pull out of the reports. So we're looking for tumor suppressor genes affecting hereditary breast cancer risk. There's actually quite a few of these. most people would probably recognize these ones here, the BRCA genes, sometimes called BRCA1 and BRCA2. And so we've known about these since the 1990s. We've got the best research on it. We've got the most in-depth guidelines about how to consider treatments and therapies. But beyond the BRCA genes, there's actually quite a few others that may cause hereditary breast cancer risk. So it is possible that you've got a relative, or maybe even yourself, you've got a genetic test that was done years ago and it looked at the BRCA genes. And that was a good place to start. But if that result came back as a negative, meaning it did not find a cause, there may be an update test that includes some of these others that we can now look for. So our knowledge is expanding and we're better able to understand hereditary risk for more families, but it's going to be more than just BRCA. This picture is not meant to be readable. So it's meant to show you a lot of dots, so you have a sense of, well, how many other genes are there? This one is showing about half of a set of 81. This is a common type of test we do nowadays, where instead of testing one or two genes, we often look at dozens all at the same time. Something else I want to point out about this is when we do hereditary breast cancer testing, it usually means it's part of a larger test. The one here would also be simultaneously evaluating for things like hereditary stomach cancers, skin cancers, kidney cancers. Unless you tell your provider otherwise, this is probably our starting place. Some individuals prefer it, hey, just figure out what I have. Don't look for other things. And others are more like, hey, if it's the same blood draw, there's no change in the process, sure, tell me what else you find. But you should anticipate that genetic testing these days, it's not one gene, it's not two genes at a time, it's usually dozens. So hereditary breast cancer is not often on its own. Hereditary breast cancer is one symptom of a larger hereditary syndrome, so a collection of possible symptoms. And these can be broken down to male and female, but also the ones that they share together. If we look on the left side, I mentioned earlier that sometimes hereditary breast cancer is associated with hereditary ovarian cancer. That's the one we've known about since the 90s. But we found out that some hereditary breast cancers can also cause uterine cancers. This is where I may be asking my patients, hey, your aunt, when she had cancer, what kind of surgery did she have? Was it a total hysterectomy, or did they only remove the uterus? Or maybe it was just the ovaries. That's going to help me hone in on, well, there could be a common type of surgery, but certain details may tell us it actually started somewhere else besides the ovaries. For men, men can get hereditary breast cancer, but you're more likely going to see prostate cancer as a result of hereditary breast cancer risk in the family. And breast cancer for men, we're seeing it about 1 in 2,000 men. So it does happen, but not very often. Hereditary male breast cancer may occur closer to about 7%. That still means that that guy has got about a 93% chance he's not going to get male breast cancer. But 7% is a whole lot higher than 1 in 2,000. So if there's male breast cancer in the family, we're going to be looking at that closer too. This middle section is what I was hoping to really help explain why this is going to affect both men and women. So if there's a breast cancer in the family and you find out it's hereditary, these are the areas that are common for the men and women, the sons and daughters, brothers and sisters. In the first example for colon cancer, you may see that there's a breast cancer and wonder, well, should I tell my sons too? Well, they've also got colons, so yes, you probably should. There are some exceptions, but in most cases, if you find a hereditary risk, we're going to recommend you inform both male and female relatives in case they need to look for things like more pancreatic cancer screening, getting thyroid ultrasounds in this list, going to a dermatologist to check for melanomas, looking for rare tumors like sarcomas or kidney cancers, and stomach cancers. This is where I'm hoping to work together as we go through some case examples. I'm going to start off by trying to define what you're looking at here, because it probably looks like random squares and circles. This is what we would call a family tree or a pedigree. You can kind of see that, like a tree, it starts small at the roots and then branches out. This arrow is pointing to who's the patient. So the arrow is pointing to a circle. Circles are females, squares are males. So if we think of the square next to the circle, we're thinking of her brother. You go down a generation, those are descendants. So the square below the circle, that's going to be a son. Circle below a circle, it's going to be a daughter. Going up the left side, that circle is going to be mom and her side of the family. That square is dad and his side of the family. So this is just to kind of get your bearings as we're going to talk through this, and I'll be labeling them as we go. In this first example, we're looking at a female patient who's got breast cancer. So that's what this shaded area is meaning. This individual has breast cancer. And that positive or plus sign is saying we've done a genetic test and we found out that she got breast cancer due to a hereditary cause. And so my question based off of this here is, if you, a female patient with breast cancer, have a hereditary risk, can it affect your daughter? In this case, yes. And you're going to be seeing this as part of a pattern. Not only can it affect your daughter, but it can affect your son too. So that positive result, that hereditary risk, could be passed on to children. Daughters with that risk may express it as breast cancer, but men may express it differently. Like a son may get a prostate cancer at a much higher rate than his likelihood of getting breast cancer. And so if you, a female patient, have a hereditary risk, we think this would be relevant for sons and daughters, brothers, potentially even others further out in the family like uncles and cousins. Where this is coming from is that all of our DNA, we're basically getting from one side or the other. So in this case, my female patient has a positive result. She passes on half of all of her DNA to her children. So daughter got her other half from dad. So we don't know until we test, is daughter positive or negative? We can't make assumptions until the testing is complete. This also means that if we're looking at, she got 50% of the DNA, does that mean half my kids will have it and half of them won't? No, it doesn't work that way. It's kind of similar to how sometimes you see families that they may have a lot of kids, but it's really skewed one way or the other. Like they had 6 boys and 1 girl, or they had all daughters. You would think 50-50 chance boy or girl each pregnancy, but that's not always the way it works out. And so yes, if you've got a hereditary risk, you could pass it on to a daughter, and you could also pass it on to a son. This is where I'm going to really focus in on the men. So given that we don't have as many men in the room here, I'm going to be like pointing to the camera and be like, hey, you watching the recording, I need your help here too. So we talked already about how men, yes, you can get breast cancer. Not very likely, but it's higher than average if we find certain hereditary risks. But we've also talked about how you could get other types of cancer. If it's not breast cancer, you might be at a high risk for a kidney cancer or a stomach cancer, and we can look for that too. But this is where I'm also going to be talking to the men about hereditary risk, about how you could play a role in helping your family members determine if they also have hereditary risks. It is really common for me to be talking with families about cascade testing. That's our fancy way of saying, we found something, see if your relatives are interested in testing. If there's a place in the family where it gets stuck, like, hey, I want my kids to test, or I want my brothers to test, it's almost always getting stuck at the guys. So women love having you as my patients. You're the ones keeping track of the family. You're the best at keeping track of family history and motivating individuals. But guys, you've got a role to play too. And I'm hoping that I can show you a little bit about how you could be helping not only your own health, but potentially that of other family members. So I've switched up the family tree here. In this case, the arrow is pointing to a square. So I'm looking at a male patient and nothing's shaded in. So you don't have any cancer. In this case, your mom had a breast cancer and she did a genetic test and they found a positive test result. So if you as a male patient, you don't have any cancer yourself and your mom finds a hereditary risk, can it affect your daughter? Yep, this is going to be part of the theme. It can. So if mom has a hereditary risk, there's about a 50-50 chance she passed on to each of her children. So you could have inherited it. And if you have it, you could pass it on to daughters, you could pass it on to sons. This is where we start getting into terms like, does this skip a generation, Stephen? I get that question a lot. And so the genetics don't skip generations, but the symptoms may appear to do so. I want to talk about that a little bit more. This is where we talk about something called incomplete penetrance. That's our medical jargon for saying it didn't show up. Why not? These graphs are based off of a BRCA2 gene mutation. BRCA2 is a gene that acts as a tumor suppressor. When it works, it helps you prevent cancer. When it doesn't work, it doesn't get the job done. Starting with the left circle here, this is for female breast cancer risk. If a woman has a BRCA2 gene mutation, her likelihood of getting breast cancer is about 69%. Compare that to average around 12%, that's a lot higher than average. But it's not 100%. This means, in this case, we're looking at about 30% of women who have a BRCA2 gene mutation will not get breast cancer. That's incomplete penetrance. That's you got the risk, you didn't get the symptoms. It looks like it skipped a generation, but you still got the gene mutation, and it could still matter for siblings and children. In this middle circle, we're talking about ovarian cancer risk. If a female patient has a BRCA2 gene mutation, their risk for ovarian cancer is about 29%. So average risk for ovarian cancer is closer to about 1.5%. So it's a lot higher than average, but it's not 100%. It's not even 50%. That means most women with a BRCA2 gene mutation will not get ovarian cancer. It looks like it skipped your generation. The gene's still there. It just didn't show up as that symptom. In this circle on the right, this is prostate cancer risk. This is a man that has a BRCA2 gene mutation. His risk for prostate cancer is around 61%. So that is not 100%. There's going to be about 4 out of 10 men that have a BRCA2 gene mutation that will not get prostate cancer. And so that's what I was trying to show in the most recent example. There was a guy there, his mom tested positive, but he didn't have any cancer. Why should he test? Well, he might have the risk, even though it hasn't shown up as a symptom. And that risk could affect him, that could affect other family members. So I'd like to go over a few more examples like this. In this case, we've got a male patient, no cancer, but his dad's sister, so his aunt or paternal aunt, had a breast cancer. If that's the case, you're a male patient and your paternal aunt has a hereditary risk, can it affect your daughter? Yes. This is another case where it can affect your daughter, but they can affect others too. in this case, I'm showing how it could affect siblings as well. So maybe you don't have cancer yourself, but you did a genetic test and it's positive. Your aunt may never have done her own genetic test. Maybe she's deceased, maybe she's opted out of testing, but you may find a positive result based off of her cancer risk. That would mean that if we're thinking this came from aunts, there's a connecting relative there. That's dad. So dad may never have done a genetic test, but if we're thinking the risk you found is from aunt, then that's something that dad had also. If he had that gene mutation, it could affect any of his children. Could affect you, could affect your sister, could also affect your brother. And so in this case, maybe you do a genetic test and you find out you're positive. Yes, I would encourage you to inform your daughter and your son. But this could be relevant for your brother and your sister. So brother may not get breast cancer, but he could get one of those other cancer types like prostate cancer. Hey, one of the things we talk about a lot in my appointments is about this idea of, does it affect only men or women? And this is where we talk through, well, what about the cancers on my dad's side of the family? I don't need to pay attention to those, right? As we're talking about today, that's not the case. And I want to explain a little bit better about why that's not the case. So when we talk about sex chromosomes, we're talking about those X's and Y's. Maybe you've heard of those before. The human body has 23 pairs of chromosomes. If you think of a chromosome kind of like in a set of encyclopedia, you've got 23 books in your encyclopedia. The genes are the individual entries in that encyclopedia. And so book X and book Y, they're going to be helping determine whether somebody has a biological sex of male or female. And so these chromosomes do not contain many genes that affect cancer risk. And so in this example, BRCA2 is actually a gene located on the 13th chromosome. So it has nothing to do whether or not there's going to be a male or a female child. Instead, this separate chromosome is helping take control of the body in terms of preventing cancer risk. So that's why when you're looking at these patterns in the family, not only may you see incomplete penetrance, like guys may not have the same level of risk or they may not have the same type of cancer, but I also want to just communicate it's not even linked to what defines biological sex in almost all circumstances. All right, so let's talk about this next example. So this is a male patient. You've got no cancer yourself, but you know your dad had prostate cancer. And dad mentioned that his mom, your grandmother, had a breast cancer. And so if this is you've got no cancer yourself, dad had prostate cancer, and his mom had breast cancer, can it affect your daughter? Yes, it can. And so even if grandma never did a test, even if dad never did a test, there may be a genetic risk that's being passed on through these generations. If it hits your generation, you may still not have symptoms, but it could still go on to the next one for daughter. Right, let's talk about this example here. This is something that may be a little bit more relevant in terms of who you are interacting with. So your sister may have given you a call. So this is often where I mentioned earlier, we might get stuck. Sister calls you, she's excited about something. She's mentioning all these terms that you've never heard of before, BRCA something and breast cancer. And it's really easy to just kind of tune that out. I don't have cancer. I'm not getting breast cancer. Why would that affect me? Well, if your sister did a test because she had a breast cancer and it came back positive, that means you've got about a 50% chance to inherit the same gene risk. It may not show itself as male breast cancer, but it could show itself in other ways. If your sister has that hereditary risk, yes, it could affect you. Could it still affect your daughter? Yes. Could affect her, could affect your son. This is where I would hope that, especially guys that are tuning in with the recording, if you're getting those phone calls, if they're getting those emails, and they're saying, hey, sister got this positive result, should I pay attention? Yeah, feel free to kind of try to understand that a little bit. What's she trying to communicate? She may be referring back to things that we've talked about in an appointment where you should tell your brothers and your sisters. And even if you don't have cancer, it could affect son and daughter. One of the reasons why we focus so much in on the men today, especially the men who don't have cancer, is because you may have the potential to really help the family not only better understand risk, but you could also help them reduce the number of tests. Now, in this example, I've been not putting a whole lot of people on the board. This is actually a relatively small family compared to the people I work with. It may be that you don't have a daughter and a son, you may have 5 children. It may not just be that you have one brother, it may be you have 4 brothers. There may be a much bigger family here. What we're trying to do with familial testing is test the people closest to risk. Keep going if you need to, but stop if you don't need to. So if sister calls and she's got a positive result and you do your test and it comes back negative, what that means is she found something. It's causing risk in the family, but you don't have it. If you don't have it, you can't pass it on to your kids. So if you do a test and it's negative, that means that we don't have to test daughter. We don't have to test son. If you've got a lot of kids, that means you don't have to test all of them. And so that's often what I'm trying to communicate when I say, hey, can we try to get brother involved? Or I mentioned earlier, where do we get stuck in the family? You may be wondering, why is everybody making a big deal out of this? It may be that your test is informative, not just for you, but for many others. In this example, I've got another unaffected male patient, and his mom had breast cancer, and his grandmother also had breast cancer. So you're seeing a pattern in the family. Mom did a genetic test and found a positive result, meaning there's a gene mutation there increasing her risk. If that's the case, can it affect you? Yes. If you've never had a cancer before, you could still get one. And that's true hereditary risk or not. But we may be seeing that you've got a higher than average risk. Maybe we can offer more targeted screenings and therapies based off of that. If this is you, maybe you haven't even done a test yet. Maybe you're a male that's been diagnosed with a cancer. Why would we still start with you and not just go straight to sons or daughters? This is where we talk about false negatives. I've been going mostly on the fact that in these examples, we found something. We found a gene mutation. But one of the things I mentioned earlier is hereditary risk is actually rare. So we see in about 1 in 20 or 1 in 10 cancers. So when we're looking for something hereditary and looking for something rare, we've got a high chance it's going to come back negative. But that negative doesn't mean there's no risk. That negative means we didn't figure it out. I mentioned earlier that we didn't have some of this genetic testing until the 1990s. Does that mean hereditary risk just showed up in the 90s and it never happened before? That's not what it means. There have been hereditary cancer cases for centuries. However, we didn't have a test to figure it out until more recently. While we know a lot more, there's still a lot of things we don't know. So if you do a test, you've got a cancer and it comes back negative, that doesn't actually mean the family's at a low risk. It just means we didn't figure out what's the cause. It could be genetic. It's not likely, but it still could be. Could be a variety of other things. So if people are coming after you and saying, Dad, can you just do the test? My doctor said you should do the test first. This is coming down to the idea of, well, if you're male and you're symptomatic, you've got 100% of your own DNA, but your children have 50% of that DNA. So if I'm looking for something rare and I'm trying to reduce false negative results, I am far more likely going to figure this out by testing the male with the cancer than somebody without the cancer who has half of that DNA. So these are at least two reasons why people may come after you guys about doing testing. Can you help others figure out, are they at a risk? Do we need to keep testing? And you may actually be a better candidate with more accurate results by testing you rather than someone unaffected. So you may be hearing all of this and wondering, all right, that's a lot to think about. What do I do with this? I mentioned last time this online risk assessments, so I'm going to go over it more briefly this time. But one way you could go about this is just go to the Bliss Cancer website. If you go to the area or the tab that's labeled genetic risk education, there's this button when you scroll down the page that says start a risk assessment. It takes you to a partner website where it tries to calculate what your risk could be. So it asks mostly for name and date of birth, but after that, it's going to ask for symptoms. So have you had a cancer? What type? What age were you when that happened? Did anyone in the family have cancer? Oh, it was your uncle? Was it your uncle on dad's side or mom's side? So it's going to go through those questions and calculate, are you meeting national medical criteria where we should be recommending you do your own test? And so that's a good place to start. There's a lot of nuances involved. That's what the appointment is for, is to customize it to your situation. But this may give you a general idea of, should I consider going in? If you do come for a genetic appointment, there are some things I think you should expect. One of them is that it tends to be a longer appointment. We've got a lot to talk about, and a lot of that comes down to the family members. If you've got a big family, it's going to take us longer. If you're an only child and only mom had cancer, we'll get through that pretty fast. But if you've got 11 cousins who have had a variety of cancers and we're talking through it, it's going to take us a while. We won't talk through every family member, but hone in on those who have had cancers. But overall, bigger family usually means longer visit. At that appointment, we also set goals together. You may simply have arrived because, my sister told me to be here. That is a common place I start at. You may also have an idea of, I want a test. I already know, and we'll work toward that goal together. But you may have more questions about, would this really help? Would it be helpful for me, or is this just for my kids? If we can determine what your goal is in this process, whether it's about you actively having a cancer diagnosis, or if we're trying to figure this out for the next generation, I can help you figure out, does the test get you toward that goal? Does it actually answer the questions you're aiming for? We do go through a health and family history out to 3 generations. So first degree, children, siblings, parents. Second degree would be grandchildren, uncles and aunts, grandparents. Third generation is mostly try to figure out, have you had a cousin with a cancer? And we're getting all of that to figure out, what's your situation? Do we have an option that may be helpful? If you decide that you're going to do a genetic test, it's basically a blood draw. It is not a fasting one, so you do not have to skip breakfast if you come for my appointment. In fact, I think we all do better on an appointment when we've had a good breakfast. In terms of the result, you should anticipate it would be a few weeks, so it wouldn't be day of. And I do call my patients positive or negative results, but this is now available in my chart, so you can have access to it that way too. We're wrapping up toward the end of my talk. I'm going to be available to answer questions that may have come to mind as you've been listening, but also if you feel like this isn't really the place where I want to ask those questions, you can set up a time for an appointment. We can talk through it then. I do want to reemphasize that the appointment itself is not a commitment to do a test. If you decide, I understand it better and I'd rather not test, that's okay. But this is to help us better understand what are your goals. Can testing help you get there? I've also got a QR code up here in case you like using your phone app for that. But you could also go to the Bliss Cancer website, like I showed you earlier. And if you call that phone number, you can self-refer, or you can have your doctor call that, and the physician can refer as well. So thanks for your time today. I'll open it up for questions.
And we'll start and see if anybody here in person has questions before we check online.
Okay, if it's a hereditary, do you find that it's going to skip an older son and go to the younger one, or an older sibling and go to a younger sibling, or does that matter?
Age does not matter, but what it could tell us is likelihood of risk. This is especially true in big families. So the oldest sibling could be 3 years older than the youngest, or he could be 20 years older than the youngest. So it makes a difference if you've got like a 70-year-old brother and a 50-year-old brother. We're actually thinking if the 70-year-old has not gotten cancer by the time he reaches 70, then it's less likely he's got a genetic risk because those tend to show up younger. And so if it was going to happen, maybe we would have already seen it. But we can't rule it out completely because of that incomplete penetrance idea, which is he could go his whole life without having a cancer and still have hereditary risk.
When you test for the BRCA, is it possible to have it show up after the test? Or does it, if it's hereditary, is it there no matter how old or young you are?
Mm-hmm. There's two parts to this answer. So your genetics are not changing. You've still got the same genetics you started out with. And so if it came back negative in the past, no, I'm not anticipating a positive result in the future. Your DNA is not changing that way. However, testing technology is changing. So I would say around 2007, our accuracy of the BRCA test was around 90%. So that means that 9 out of 10 women with the gene mutation get a positive. But 1 out of 10 women have a positive result, but the test missed it. So that's a false negative. In 2008, they came out with a test called ART. It's an acronym, but it's basically their type of test that said, hey, we're going to do a secondary method to look for gene mutations that would have been missed by the primary method. And that got us up to closer to 93 to 94% accuracy. So in that case, the likelihood is pretty low. You know, change of 90 to 94%, that's not a big jump. But you know, if you look at 100 families, that means that's noticeable. There's going to be 4 additional families that find something. So your genes do not change that way, but the testing technology may get better and you may be able to find something that was missed before.
Any other questions here in the room?
And can you tell us why everyone shouldn't get a test? If it's just a little blood test, like a flu shot, why don't we just go do that?
I think it's a great idea to just go do
Is
it.
it very expensive or
In the eye of the beholder. So I'll try to explain it in a few different ways. A lot of this is coming down to how genetic testing was done historically and how we're adjusting to where we are now. So genetic testing was very expensive for a long time. So one of the things I keep coming up with in patient appointments is people ask me, what's the cost? And by the time I tell them, they're like, oh, phew, I thought it was thousands. Well, it used to be that way. Nowadays, most tests is around $250. So that would be, hey, I'm just gonna, you know, I'm just gonna pay for it. Let's just get it done. That's usually about $250. For some, that's easy. For others, that's a more difficult amount to come up with. In terms of should you just do it, it depends on who you ask. So there are going to be individuals that are more cautious, especially when we talk about a variety of result types. One of the things I didn't mention much today is a type of result called a variant of unknown significance. This means that we found something unusual in the test, but we don't know what it means. So for some people, that's going to cause stress. They're thinking, oh, do I have a hereditary risk? Statistically, no, probably not. But that idea is in the back of your mind of I found something, I don't know what it means. That causes some undue stress. Others are okay with that. I don't know now. I still don't know after the test. I'm okay with that. And so that might be, you're in a really good position to just do the test. I do think it is still more valuable to try to target the people who are most likely to do a test. So if you've got, 30 people you meet with at a family reunion and 4 of you have had cancer, well, those are the 4 people I'd probably focus in on first rather than test all 30. Anybody may find something, but usually we try to take a more targeted approach, but anyone could do a test if they wanted to. Did I address that question that you had?
Yeah, and you may not know, but does insurance cover it?
Yes, so
So again, why not?
so it does depend on the insurance, but in most cases, if you're meeting national medical guidelines, it's no cost to the patients. We also tend to work with laboratories that kind of have a fail-safe built in. So we don't actually know, in a lot of cases, we don't know if it's covered until we try. And so if you're in one of those rare situations where insurance is just not playing along and there is an out-of-pocket cost, if it is more than $250, most of the laboratories we participate with will call the patient proactively, meaning, hey, we did this benefits investigation. We found out it's going to be $300 or it's going to be $251. Do you still want to go through with it? And you can decide, hey, let's keep going, or you can cancel at no charge. So yes, most of the time insurance will cover the test if we're meeting those criteria. That was from earlier in the talk when I mentioned patterns, what type of cancer, how often is it showing up in the family? Is it at young ages? Are you getting cancer more than once? You're meeting those, then yeah, it's probably covered.
Thank you.
If you've got a parent who never went to the doctor and died at a young age, and his father was the same way, is there any point on that side?
That is a limitation. This is the same sort of thing that comes up with adopted individuals. So sometimes, that generation just didn't go to the doctor. And if they did, they sure didn't talk about it, especially not to you. So as far as where do we go with that? It kind of depends on what question you're asking. If your question is, hey, could I just get a test and see where I'm at? Or maybe you've got a more specific idea of, my friend just got a melanoma. I want to do that test. I may, counteract that and I don't know if we're going to find a hereditary melanoma specifically if we don't see that in the family. We're going to talk through where the limitations are. The lack of family history doesn't prove much. So there could be a hereditary risk, especially if they died young. They may have died before cancer ever showed up. So we really see it as kind of it's not really much of a decider. We have to figure out if we're going to do a genetic test based on something else, based on your goals, other types of cancer in the family, your own health history. We're going to focus on those instead.
Okay, I have a question, and this is from a long ago. They said that there's 3 things they use to discriminate against you for getting it done. Is that still true today?
Yeah, so I'll talk about what protections we do have, then I'll highlight a few that we don't still have. So the main protections that we have are that the genetic test is a medical test. So in this case, we're ordering through a medical provider, it's signed off by a physician. I'm not going to go too far into the stuff you see on TV or online. Those are not medical tests. They've got their own uses, but you'd have to look at their own fine prints. But if you're doing it through the medical provider, then it's a medical record. It's protected under HIPAA. So if somebody asks you for records, you can choose not to give them out. Doesn't matter if it's genetics or cardiac or it's an animal physical. You can choose not to give it out. We do have specific protections in place for genetic testing with health insurance and employment. This is a law that was passed in 2008. It is not connected to other laws like HIPAA or the Affordable Care Act. So this is its own law that basically states it's illegal for health insurance and employers to discriminate based on genetic results, even if they get a copy. That means health insurance not allowed to drop your coverage or change your rates. That means employers not allowed to hire or fire based on genetic testing. So those are for sure. The exceptions for that are more along the lines of if you get your healthcare through the military or a Native American reservation. For military, it's more about are we going to find something that would prove that you're not fit for service? And that's really more along the lines of things like cardiovascular disease, epilepsy. I'm not too worried about that for hereditary cancers, but it may also be just doesn't matter anyway if you don't have insurance through the military. So the things we don't have, basically, we don't have anything else besides those two categories, health insurance and employment. Outside of those two categories, it's just treated like any other medical record. So it's treated like a medical record with life insurance, with disability insurance, with long-term care insurance. And so you don't have to give the information out. That's HIPAA. But if you do give the information out, they could use that for discrimination purposes. I really have not come across any cases with my patient where we've been able to determine, hey, there's a discrimination here with life insurance. We haven't found that. It's just, we can't prove it couldn't happen because we don't have a law around it. It's just another medical record under HIPAA.
If you want to make an appointment and you have an extended family, do you need to have written out at that first appointment what everybody died of or what kind of cancer they had?
That would be really helpful.
And in
So,
what age?
yes, it would be. And so a lot of the things we're looking for is who in the family had cancer, what type, and what age. If you can get those three things, we're off to a really good start. Now, there are going to be gaps where you don't know those things. Like, that relative died young, maybe it was cancer, I don't know. We're going to use what we have. There's not a single patient I've ever had that knew all the information. So I don't know is a common answer, and it's an acceptable one too. We use what we have.
Any other questions?
So just to understand kind of the system, you want the person to take the online heredity before you would make an appointment? You have to take the online before you make the appointment? I guess I'm not quite sure.
Yeah, the easiest way, if you want an appointment, just call us. We can schedule you. This assessment was generated for a few different purposes, but one of them is sometimes people just want to get an understanding of, should I look at it closer? Like, I don't want to call up my doctor. I don't want to cause a fuss. I want to take a short online quiz and just get an understanding of, should I ask my doctor about it? So if you already know you want testing, if you already know I want an appointment, just call us. That's fine. But this is more for people who are wondering, hey, should I look at it closer?
Any other questions? You got them here. This is the time. All right. Well, thank you so much, Stephen. You do a very nice program, lots of great information, and can you stay around a few minutes if people want to come up and ask questions? That would be great. Yes, very good. So please fill out your evaluations. Give us topics for other presenters, or give us ideas for other presenters, other topics that you would like would be great. And there's a basket on the back table as you go out. I want to remind you, our next program is actually an AARP Smart Driver course. It's a half-day course at Mary Greeley, Wednesday, November 12th. If you take the course, you may get an insurance premium discount on your car insurance. Not all do it, but many of them do it. And it's great information about how driving maybe changes as we age and ways that you can adjust for that. It's a great program. And then we will be back down here, our next program, that same day, Wednesday, November 12th, 2 p.m. It's Continence Depends on You. And we have one of our physical therapists who will be here giving that program. And then we'll be back at Mary Greeley Wednesday, November 19th at 2 o'clock on protecting your vision as you age. So thank you for coming out today. Thank you, Stephen. Great program, and have a wonderful day, everyone.